There's one other person before I introduce our first speaker that I wanted to announce and acknowledge. That is Ms. Karen Gilmore. Karen is the Vice President and Regional Executive at the Miami branch of the Fed Reserve Atlanta office. Karen was instrumental in helping us to get this to come together. Karen, myself, and others are all board members of the Health Foundation of South Florida. And through some of her vision and the support and leadership, today would not have been a possibility. So thank you, Karen. She had a previous commitment and unfortunately could not make it today. So thank you, Steve and Todd, for the welcome. And it is now truly an honor and privilege to introduce two colleagues, two buddies, partners in arms, leaders in the field of community movement, healthy communities movement. That's Dr. Doug Jute and Dr. David Erickson. Doug, David, and I first met and brainstormed about having this meeting 5 to 6 years ago. And we said, oh, wouldn't it be great to bring together all these really smart folks to talk about these issues? And just wasn't right. And as you know, timing is everything. But they have been steadfast partners in supporting us in making this a reality. So very briefly, by way of introduction, Dr. David Erickson is the director of the Community Development Department at the Federal Reserve Bank in San Francisco, and as you heard from Todd, has been one of the visionary leaders to really step out and push the Fed Reserve to take this leadership role around building healthy communities. Dr. Jute is the executive director of the Build Healthy Places Network, one of our key partners that were essential in helping us pull together this meeting. And that's a national organization that catalyzes and supports collaboration across the sectors of community development, finance, and health. So please join me in giving them a warm welcome for Dr. Erickson and Dr. Jute.
So welcome, everybody. My name is Doug Jute. I'm really glad you're all here. I want to thank Roderick. I want to thank the Health Foundation of South Florida. I want to thank Gretchen at Catalyst Miami and all the folks who made this happen and paid for this to happen. David and I are excited to be here. We are going to do sort of a joint presentation in order to really emphasize the contrast of having a doctor and a Federal Reserve health economist, an economist, economic historian on stage at the same time, because we think this work is so important and it sort of resonates when you have a little bit of a broader perspective. I'm going to sort of overview the why we actually believe that health is tightly tied to community development investment. And then David's going to talk about what the community development really means, what community development investment really means. So as Roderick said, I'm at the Build Healthy Places Network. We've been around for about 4 years. And the reason I actually left my clinical practice to do this work is because I feel like I have more opportunity to affect the health and well-being of the children I serve. I'm a pediatrician this way than I was through my 20 years of seeing patients on a one-to-one basis. What I really believe is the work that many of us are doing here in this room around community development is creating a health return on investment. There's a health ROI that is not being measured adequately, is not being taken into account, and is definitely not being paid for. And that's part of what we'd like to change over time. So one big question is why do we have to have this discussion? And what you see here is a graph of basically the impact of our healthcare dollars on our health here in the US. And you see this as a comparison across countries. You see dollars across the bottom and you see life expectancy on the left side. Based on what we spend, we should have a life expectancy of almost 82 years. Where is it actually? 77 years. You see the red dot there. That puts us about the same level as Korea, Portugal, Denmark, yet we are spending 2 to 3 to 6 times more than those countries per person. And you see we're well below other countries that are spending only half. So we are not getting a good bang for our buck. The problem, as Roderick said, he's actually slightly off. It's more 3.5 to almost $4 trillion right now that we spend on medical care. That's a really big number. Anybody know what 1% of $3.5 trillion is? 1% is $35 billion. And that's important. That's another number that's frankly too big to wrap your head around. The way I really thought about it is we live in California, And you guys may remember that dam almost burst last year. During all the rain came out of nowhere, the drought ended, the dam almost burst. There were stories in the paper about the fact we can't possibly fix all the dam. There's enough dams that have human lives at risk if they were to break. Across the country, they said we can't possibly fix them. It would cost us $20 billion to fix all these dams. One $20 billion expenditure would fix every dam in the country that's at risk. 1% in 1 year, 35 billion is what we're talking about. The scale is just outrageous. This resonates with me because I started my career in East Palo Alto, so a community near Stanford. It's one of the poorest communities in the Bay Area. The facts that were facing the families there were not their medical care. These were healthy families, mostly Latino immigrants. I could provide them good care. What I could not provide them was a safe place to live, a quality house, the social capital that they need to succeed. And I realized that what I was doing as a physician was really not making a dent. And that's, again, what slowly led me to where we are now. Because where we spend that $3.5 trillion is on medical care. This is a pie chart of what they call the contributions to premature death. So what we believe are the important factors that lead to shorter lives. So you can see here only 10% is really thought to be due to medical care itself. It's kind of mind-blowing. And yet, over 95% of that $3.5 trillion is spent on that 10% slice. Where do a lot of us here work now? Where do you guys work? You work in these other sections: social circumstances, behavioral patterns, environmental exposures. And how many of you have heard of the term epigenetics? Wow, very nice. There's some hands held up. So genetic predisposition is, we now know, this information you can see is from the early 90s. It's old enough that we now understand a lot of the predisposition is really those genes are turned on and off by your social environment. So that really is also due to the physical and social environment that you live in. So the bulk of what causes health or early death is not due to medical care, it's due to the community.
Hey, Doug, hold on
Yep.
a second. So let's ask real quickly, how many people here are in the medical community?
Most not. Okay, that's what we sort of suspected.
Okay, how many would you consider yourselves in the community development sector?
Oh, yeah,
Wow, okay,
Good.
all right. And if you're not one of those two, what are you? Transportation? Education?
Education, good.
Excellent, those are all essential.
Government. Oh, yeah, government. That's right.
Good.
Yep. Banking. Good. All right, great. So so what is health if it's not medical care? This, interestingly, goes back to 1946. This is the World Health Organization. Complete physical and mental and social well-being. I think it's a beautiful definition that should resonate with those of us that work in the neighborhoods. So if it's not medical care, what is driving health? It's really education is one of the primary drivers. What you see here is a graph. This happens to be for men, but it's life expectancy at age 25. So it's a slightly funny chart. But what you can see is at age 25, you've got between 47 and 56 additional years that you can expect to live. The darker bar is for those who have less than a high school degree. The lighter bars are those who have a college degree. So it's a huge gradient across that range. Education drives it. Income drives life expectancy. So this happens to be children with less than very good health. So it's a flip direction. So you see the lowest income children, less than poverty level on the left. 30% of those kids have less than very good health, compared to just 7% of those that are greater than 400% of the poverty line. But what's important there is you notice it's not an either or. In this country, we tend to think of the poor and the non-poor, but that's not actually true. Every level of education and income makes you more or less likely to be healthy and live a long life. Another issue that comes up is race and ethnicity. This is the same chart. This is adults, but the same as the child chart. So this is a percent of adults with poor health. Dark green is the low-income adults. Light green are the higher-income adults. What you see, so the left set of bars is the blacks and blacks. The middle is Hispanics, and the right are whites. What you see at every level, there is a modest, African Americans and in most cases Latinos are slightly worse off, but what's really driving this is the gradient across income and across education. There are important racial and ethnic distinctions, but the real driver tends to be poverty. And that's important because this graph shows the percentage of people who live in low-income neighborhoods. Concentrated poverty is predominantly in the United States an issue of Latinos and African Americans and other ethnic minorities. So what you see here on the left for all persons, 27, 25 to almost 1 in 4 Latinos and African Americans live in low-income neighborhoods compared to about 1 in 10 for Asian Americans and whites. For children, it's even worse. Fully a third of US children of color live in low-income neighborhoods. This drives immense disparities in health outcomes. And as Roderick had said earlier, your zip code is more important than your genetic code in determining your life, health, and future chances. That, by the way, is, I think, the local zip code. Is that right? Or one of the local zip codes? One of, yeah. I think I looked up the Health Foundation of South Florida. So what's driving this? Have you guys heard of the term social determinants of health? Okay, so that's, now what's interesting about that, as much as people were nodding, and I'm really glad you are, when I started my fellowship program, when I left my clinical practice, social determinants about 15 years ago, that was an unheard of term. No one was using that language because doctors said it's all about the quality of our medical care. You can see a number of these things. You can imagine these are the factors that were affecting the kids that I was seeing in East Palo Alto. And it's important too that there's a sort of the shape of a baby there. These impacts are greater in early childhood and they get embedded. There's something called biological embedding. There's changes in your actual physiology that can last a lifetime. The primary driver of this what they call toxic stress. Toxic stress is not the stress of, say, standing in front of a group in South Florida giving a presentation or flying a plane across the country from San Francisco to Miami. Those are stressful, but if I got really sick, I could just hand the whole thing over to David. Or if the pilot's spouse got ill, they could take a day off work. Toxic stress is not knowing how you're going to pay your bills next week, whether you're going to lose your house or your car next week. That's that not knowing what's coming gnaws at your physiology, gnaws at your health in a really fundamental way. And it plays an important role in a number of the biological systems that lead to health and well-being. And this is all knowledge that's really been accrued in the last 12 to 15 years. So this is really new. The immune system is affected. David likes to tell the story of a researcher in Pittsburgh looked at college students and actually put cold virus in their noses to determine who is more or less likely to get a cold. Turns out those kids whose parents owned their houses versus those whose parents rented, those who rented their house when they were children were more likely to get the actual cold. That's a proxy for poverty in that particular case, but it was happening a decade, 2 decades later that this was showing up in their actual physiology.
And it wouldn't matter how wealthy they were
right
at that age. Like it's the damage was done at 0 to 5.
Inflammation. Heart disease is really an inflammatory disease. That's one of the big drivers. The fight or flight response, how quickly you respond to a stressful environment, like getting an unexpected parking ticket or a call about a bill. Your ability to calm back down after that is influenced by the toxic stress. And the most pernicious is brain development. Young children, their brain development, especially the prefrontal cortex they call it, which is your executive function. It's your ability to self-control. It's your ability to modulate your emotional response. Your ability to concentrate is harmed by toxic stress. This then leads to a difficulty doing well in school, difficulty doing well in jobs, and is now thought to be a primary driver of intergenerational poverty. So how does this play out? So we talked about, so this is actual maps of what Roderick was referring to around zip codes. So what you see here is New Orleans, which is one of the more extreme examples in the US. 55-year life expectancy in the center of the city compared to 80 only 3 miles away. This is life expectancy at exit ramps. Ponder that, 25 years. And by the way, life expectancy at 55 is the same as sub-Saharan Africa, right here in the United States. Now, New Orleans is a complicated city, right, for lots of reasons. How about Minneapolis-St. Paul, one of the wealthiest, healthiest, well-run cities in the country? You see in the lower left, 13-year life expectancy at 2 different exit ramps. When they interviewed folks at those exit ramps, when this map came out, they interviewed a guy at the lower left and said, you know, what do you think about this? He goes, well, I'm going to move to the other exit ramp. And that's sort of the idea, right? He knew exactly, without even talking about it, he knew exactly what this was demonstrating. And this is a map that I just pulled up yesterday from Miami. So just to highlight, you see there's the 2 and the very bottom, 86 years life compared to 71. Probably, what is that, a mile apart? That's 15 year difference in long-term life. And if anyone's nearing 70, imagine knowing that you're hitting your life expectancy. So I'm about to switch to David. So how are we currently solving this problem? So my mentor at UC Berkeley talks about health as being a curvy road in the mountains where there's a certain rate of people that aren't paying attention and you drive off the cliff and go careening into the bottom of the valley and just end up at a pile of rubble at the bottom. So what have we done? We've built a hospital at the bottom of the cliff. And what I like to think is that the work you're doing is actually working on the road. So I'm going to hand this over to David.
Great. Thanks, Doug. So it's interesting. We at the Federal Reserve, and along with the other government agencies that regulate the banking system, have a conference every other year for those who are investing, the bankers who are investing in low-income neighborhoods. And last year it was in Los Angeles. In March, it's going to be here in Miami, by the way, and we'll be bringing 1,500 bankers here. So I hope you guys get a chance to sort of attend that conference. But we had two speakers in that conference that really kind of crystallized some of this thinking. One was my bank president, John Williams, and he got up and he said, you know, and these were older numbers, right? That you've seen this 3.2, 3.5 trillion spent a year, but he was talking, we were fact checking a lot of these numbers because we do that at the Federal Reserve. And it was about 2014 numbers, $3 trillion spent a year on medical care. 80% of that is on chronic disease. Most chronic disease is avoidable. Most chronic disease that's avoidable is generated in low-income neighborhoods, which is why my motto is the status quo is stupid and expensive. That we could spend that money much better and avoid that illness from happening in the first place if we could reorient some of these systems. Now, he was followed by Risa Lavizza-Mourey, who at the time was head of the Robert Wood Johnson Foundation, and she had this powerful statement where she said, those of you community developers, you bankers in this room, those of you making investments into low-income communities, you are the most important health workers of our time. And a lot of them parents wanted them to become doctors in the first place, so they're very happy to hear that from a geriatrician. Now, Roderick brought this up, you know, this idea that we're working side by side, but we're not really coordinated. This is really a problem. Now, this map is very hard for you to see in the back, I know. This must be like the lowest ceiling of any room I have ever seen. I feel like I'm gonna like scrape my head here. But this is LA County, and these are heat maps. So the places light up that are of things of interest. On the left is economic hardship. So the places that are lighting up are things like South Central Los Angeles, Long Beach, some other areas. And the one on the right is the same exact geography, but now we're focusing on childhood obesity. And what you see is they're the exact same map. In every single community we go to, this is true. And we could easily do overcrowding and housing on the left and asthma on the right. Or we could do unemployment on the left or poverty on the left, and we could do type 2 diabetes on the right. They would all be the same map. We were working side by side, but we're just not coordinating to help those communities. Now, I want to give, for those of you who are not community developers, I want to give you a sense of what community development does. So community development, and I'll get to some numbers to give you a sense of the scale of it, but basically we are trying to sort of, we're in the zip code improving business, as Doug just mentioned. So we build charter schools, for example, grocery stores and food deserts. Todd Green just led a really remarkable effort with the Federal Reserve and other partners on job training and how we could be better at that across the country. So access to jobs, small business lending, we do quite a bit about that. Housing, we build affordable housing. We also, you're going to hear from Marty from Isles later about how we rehabilitate housing and make it better and more suitable for habitation. We engage with the transportation sector to sort of try to co-locate our affordable housing with train stops and other transportation efforts and try to see if we can't coordinate that more effectively. And we try to find ways to finance parks and playgrounds. So there is a huge effort here to try to make sure that every neighborhood is salutogenic, health promoting. Now, what's the scale of that? Oh, sorry. So this is, I wanted to sort of say, this is in contrast to sort of this new system of building better neighborhoods is in contrast to what was done in the 1960s and 70s and 80s and before. So this is the Pruitt-Igoe homes. They were designed by the same architect who designed the World Trade Center. This is, the smartest people in the world were designing these communities, and you'll see that these were, really dominated by that idea about towers in the park. You've got plenty of open space. There's a school there. There's public transportation. There's a church there. What really remarkable for us in San Francisco is there's plenty of parking. So this is a community that really works. But within a few years, this place really turned into a disaster. In part because, one, the people who lived in these buildings were never consulted. Right? This was just kind of dropped down from the sky, basically. And the management was so poor that it really didn't really respond to the needs of the community. So community development or urban revitalization got a bad rap because of some of the bad policies of prior eras. But I wanted to contrast that to what goes on now. So this is an affordable housing project near San Diego, California. And I used to do that work about 175 years ago. And when I was underwriting these apartment buildings, my rule was, could I have my mother live there? Would it be nice enough? And your mother would love to live here, right? This is a beautiful project. There's about 3 million apartments built with the low-income housing tax credit since 1987, housing about 10 million low-income people. It's a huge, successful program, and every single one of those apartments is a place that you'd like your mother to live in, right? Very high quality. It's maintained. So when people say you can't do it, it can't be done, I'm telling you, it can be.
It's Columbia Park.
Columbia Park in Maryland. This is a charter school in Atlanta.
Actually, yeah.
This is the East Lake community in Atlanta. This is the Drew Charter School. I mean, can you believe that this is a school that was in the poorest neighborhood in Atlanta? They called it Little Vietnam, not because it has a lot of people of Vietnamese heritage, but because it was a war zone. This is the place. This is the school that was built in that community. It now has a graduation rate of 100%. 100% of those kids graduating from this high school are attending college or going to some kind of a training program. In a place that had less than 30% a graduation before the revitalization that took place in the East Lake community. Lots of focus on small business development, you see, and really a focus on access to sort of a fair and equal access to credit. So you see, here's an example from Houston where you've got an alternative to payday lenders and check cashers here with the credit union, Chase Bank here. And this is a part of Houston where I was giving this talk years ago in Houston, and it was built on the site of a federally qualified health center. And the woman who was in the audience said she was a nurse there in the 70s and 80s. She said she had to have an armed guard walk her from her car 200 feet to the door of the clinic. This is on this same property. This property was built with the input of the community. It was driven by what they wanted. There is no security here. It has not been vandalized. There has been no crime here whatsoever. And so when you work with a community, when you engage them, when they build what they want, they own it, right? And it becomes an asset that stays. So how big is this? Well, about $150 billion annually. A lot of it is driven through the tax credit, the tax code. At least it was until about 10 minutes ago. So we'll see what happens. But there's pretty significant amount of money coming through that, and also the community development block grant program. You also have the different programs within the new markets tax credit, which focuses on. There's a housing tax credit. There's a new markets credit, which is really focusing on small business. You also have philanthropy and mission-related investing. By the way, for those of you who this is your first time you got together with a cross-sector group, when we say MRI, those of us in finance think of mission-related investing. Those of you in health think of something else. It gets very complicated when we think about CDC. That's for us, that's a community development corporation, and for you, it's someplace in Atlanta. But so the language gets very complicated. In fact, Doug has something on his website called the jargon buster that I think is very helpful. And then you have for-profit banks, and they're really the big dogs in this effort. I mean, they really are the ones who are providing a significant amount of debt and equity capital to low-income communities to build those beautiful buildings I've been showing you pictures of. And it is interesting, you know, those of you who are in health, sometimes we say debt and equity, and they're like, I don't even know what you're talking about. Like, just say money, because we don't quite get it. So we want to be really careful we're not using, that we're using each other's languages, constructively. But there's a huge ecosystem that engages in community development. And one is these nonprofit banks called community development financial institutions. There's the Opportunity Finance Network is an umbrella organization. There's an organization within Treasury called the CDFI Fund that really funds these organizations in a significant way. Lots of examples of these. You've got a lot of the Community Development Corporation, Housers, again, a lot of these different communities available. You've got some great ones here. The national, one of the co-sponsors of this event, one of the best ones, the Neighborhood Housing Services of South Florida. And I wanted to show you this kind of array of institutions, in part because sometimes we'll have this talk and we'll go talk to somebody at a hospital and like, oh, I get it, I'm going to do it, I'm going to start a CDFI. That's not the message we want to send to you. You wouldn't build your own ambulance, you wouldn't build your own computer, you've got a whole sector you can partner with, and we want you to know there's 1,000 CDFIs, there are 4,000 community development corporations, there are plenty here in South Florida. You want to partner with them, don't duplicate their efforts. I want to go through quickly a few examples. This is the Conway Center in Washington, D.C. It has been funded by the Healthy Futures Fund, which is a $200 million fund that's been, Morgan Stanley is the one behind it. They're the ones with the biggest amount of money in that $200 chunk. But it's also got money from the Local Initiatives Support Corporation, one of the CDFIs that I mentioned, a nonprofit bank, and the Kresge Foundation. And what the goal of this fund, which finances affordable housing and clinics, is what they're trying to get back is this idea that was very present in the war on poverty, where federally qualified health centers had a community-oriented primary care philosophy, and that is, you don't just care for the patients that walk through the door, the whole neighborhood is the patient, right? This is a clinic on the first floor where the whole neighborhood is the patient. 200 units of affordable housing are present here. This is, the nonprofit sponsor here it's a faith-based initiative called So Others Might Eat. They have a job training center, a test kitchen. They're next to a metro stop so that the residents of this community can access jobs and opportunity throughout the Washington, D.C. area.
But you can see all the social determinants, many of the social determinants simultaneously. It's not just housing or just education, it's those things together, which is what I think really makes that work.
Here's another example. So that's a clinic working with affordable housing developer to get something done with a bank finance, right? Here's an example in Stamford, Connecticut. These pictures are blurry because Doug took them. We'll have to get better pictures than that. But it was interesting. There was a public housing project next to a tower that the hospital was wanting to redevelop, and they needed that land. And so they made a deal. The housing authority in Stamford said, okay, look, we'll tear down that project, but we need land in exchange for that. And for whatever reason, the hospital owned lots of plots of land around the city, 7 in this case, and they said, sure, we'll do a trade. So it's a land swap. What the housing authority got was 7 sites integrated into the community, so you no longer had that concentration of poverty into one place, and enough resources they were able to free up to build, not only replace every single one of those apartments, but also add mixed income or market rate housing, so that in this top picture on the right, you barely see, but it's a beautiful colonial style townhomes rather, and they're integrated. You don't know if you're low income or if you're a market rate a renter. It is entirely segregated by door, and it's a beautiful, lovely community. Mm-hmm. United Healthcare is a really interesting player. You know, not only one of the largest health insurers in the country, but they also have, this is a project that they invested in Austin, Texas. It's for formerly homeless people, very service-enriched, service-intensive housing there. What United Healthcare found was that for many of their Medicaid patients, that when they were stably housed, they were better able to case manage their clients. and they were able to save some real money. Now, in this case, United Health has taken that to a totally new level. They have made a $20 million investment with Chicanos por la Casa, a community development corporation in Arizona that's now they're just for giving them 2% money. They're not even going through the low-income housing tax credit program anymore in order to sort of provide more housing for their policyholders so that they can stabilize them and better case manage them, and they are making a significant return by blending those two investments together. So we talked about a clinic and affordable housing developer. We talked about a hospital and a housing authority. We talked about a health insurer making investment in housing. Here's an example of the city with the Children's Hospital of Philadelphia co-investing. They built a library, a literacy center, a clinic, pediatric clinic, an adult clinic, and a recreation center, all on one site, and they were able to merge those two investments, $40 million from the city, $40 million from the hospital, using the new markets tax credit as a real sort of a driver of the financing of that project. So all of this is to say, this is a book that I'd really recommend to you. It's called Investing in What Works for America's Communities. It's available for free. You can get it at whatworksforamerica.org. It's a book we did with the Low Income Investment Fund. But there's one line in there that I think is really powerful, and that is from Risa when she was still at Robert Wood Johnson, and she says, "We are going to look back on this time and wonder why community development and health were ever separate industries." And I feel like you are building that community here, you're building that future here in South Florida, and we're really excited to participate. I do want to say this is the 37th meeting of this effort at bringing people together with health and community development. The last one I did was in Helena, Montana, at our branch there. And there were twice as many people there during a snowstorm. So next time we come back, I want you to bring 3 friends, and not to be mean about South Florida, but we need more enthusiasm, more people involved in this. So thanks very much.
So our takeaways, and we may have time for a couple questions, really is, and we've heard this now, working in the same places, often with the same people, and really the way we at the network think about it is that we can have a greater impact by working together. And in part because community development and health bring different expertise and different resources. So community development brings financial expertise. Those of us in health don't know how to build things. Infrastructure resources, the ability to intervene on neighborhood level social determinants of health. Health and healthcare, of course, bring the idea of metrics. How do you measure health and well-being? We know often where the communities are that are the most expensive and the most needy. And the opportunity to guide, that's actually what I tell a lot of my public health and medical colleagues. It's not about community development giving you money. It's about this money is going into the ground, and if it can be done in a way that's more impactful, it will be better for everyone. And with that, we'll end. These are our email addresses and a couple of the resources. The other book, that's my website on the bottom. We have a lot of resources for folks exactly like you to try to make this understandable and easily shared. And the other book that David just published, a couple months ago?
Yeah.
Is called it's Investing in Results, but it's really looking at outcomes-based finance. How do you look at what the goals are and then pay for them based on those long-term goals, rather than what we tend to do now, which is build housing because housing is good. Instead, we should be focusing on our people's lives improving because of the housing. And however we get there is the way to for everybody to win.
And we're getting the hook, so
Okay,
we're going to
good.
take some questions, but we're not going to do that. I would just say on that book, it's a playbook for anybody who is interested in building a population health business model, how you improve the health of the population. There are lots of great ideas in that book. We'd love to share them with you. We'd love to bring the book back to this community in the future.
Free.
And it's also free, a joint project between our bank and the Nonprofit Finance Fund. So thanks, everybody. Thanks very much.
Thank you, guys.